All right, guys, so we're gonna do the DNR one now, and I will tell you, this is the Ohio Department of Health Do Not Resuscitate presentation. That's what it is. This is not a presentation designed specifically for first responders. This is the presentation that, hey, I wanna go get DNR paperwork for my mom, dad, whoever, and I wanna be educated on it. This is available on the internet, on the Department of Health's website, where you can go and get more information on DNRs. That being said, we're gonna go through it and then we'll spill out how that applies to us. So one, you'll know how the general public's being educated. So it might give you a better understanding of how they're educated for it. So I think this is pretty self-explanatory. What is a DNR? It's a do not resuscitate order. It allows the individual to document their choices related to CPR, whether they want to receive it or not, basically. So what is CPR? Cardiopulmonary resuscitation includes administration of chest compressions, insertion of an artificial airway. Doesn't mean you can't bag somebody. Administrative of resuscitative drugs. Again, D10 not being resuscitative, morphine not being resuscitative, okay? Defibrillation or cardioversion, provision of respiratory assistance, initiation of a resuscitative IV line, or cardiac monitoring. And we're gonna talk about all those, okay? So, this is the state DNR form, okay? This is the approved state DNR form. It has to be filled out in its entirety, has to be signed, has to be the original, not a copy, technically, okay? That's all the stuff it has to be. What I want you guys to look at is two different things. You have DNR Comfort Care on the top, and then you have DNR Comfort Care, DNR Comfort Care Arrest on the top, and then DNR Comfort Care, okay? So, take all this away, okay, and just look at DNR Comfort Care Arrest. If you read that Stein, it says we will do everything in the world up until the point that person stops breathing or stops having a pulse, right? So there's no question. A DNR-CC arrest, you do everything until the point they arrest, then you stop, okay? It's pretty self-explanatory with that one. Because people are like, well, can you put them on a vent? They just had no money. Absolutely, it's an arrest. You do everything until the point they arrest. This is the one that causes confusion for everybody, the comfort care. And it basically breaks it down for you. Providers will and providers will not. So let's just look at them for a minute and we'll talk about it, okay? So providers will, and I gotta get over here so I can read it a little bit better so I'm not messing something up. So we will conduct an initial assessment. We will perform basic medical care. We will clear an airway of obstruction or suction. It means you can do a foreign body airway obstruction. You can lift in there, stick your finger in there and clear it, okay? Suction them out, bag them a couple times, that's perfectly fine, okay? You are able to do that, okay? If necessary, for comfort or to relieve distress, may administer oxygen, CPAP, or BiPAP. So we're not going to insert an artificial airway, but we can put somebody on CPAP or BiPAP. It's perfectly acceptable on a DNR comfort care, okay? And I look at those as you're providing a treatment, you're not resuscitating the patients. You're treating something, you're not resuscitating. If necessary, may obtain IV access for hydration or pain medication to relieve discomfort, but not to prolong death. So again, we're not gonna give fluids or electrolytes or anything that's gonna prolong their life. We can start an IV, we can give some pain meds and stuff, but we're not doing it for the purpose of resuscitating that patient or prolonging their life. And then make contact other appropriate healthcare providers, hospice, home healthcare physicians, okay? All right.
But
so those are the things we will do.
You can still fix underlying conditions.
Absolutely, and that's what we're gonna talk about, yep. Yep, so for right here, what we will not do, we will not perform CPR. Everybody familiar with CPR, cardiopulmonary resuscitation. Resuscitation being the key word. We're not gonna put hands in the chest and start doing CPR. Resuscitative medications with the intent of restarting the heart or breathing, okay? Resuscitative, so if you have AFib with RVR and you're just gonna slow the heart rate, are you resuscitating that person? No, you're treating the condition, right? If you have somebody who is got a blood sugar of 40 and you're giving them sugar, are you resuscitating them or just treating the condition? You're treating the condition, okay? Now, could I argue that if you're an SVT and you're gonna give a Denacard to restart the heart, would that go against what this says? It does to some extent, okay? Because that's more of a resuscitative type thing. So you have to kind of look at it, are you treating or are you resuscitating? Because there is a difference, okay? Insert an airway adjunct. So again, To me, that's nasopharyngeal airway,
You're saying
oropharyngeal.
a Denocard is resuscitative?
Because it says it's starting or stopping the heart. Administrative medications that with the intent of restarting the heart or breathing.
It's more resetting.
It is resetting.
You're I say you're stopping the heart.
It's a
You're not
control
trying to
delete.
restart it, you're stopping it.
And you're not wrong, and I guess that's a very bad example. I will agree with that 100%. That's a very bad example. Because go ahead,
But
Steve.
the last bullet point contradicts that you would give SVT anyway, because
I know.
Because you're not gonna put them on cardiac, and I was gonna get to that one.
continually
in a minute.
cardiac monitor.
And I was gonna get to that one in a minute, because people don't agree with me 100% on that one as well. And I'll be the first to admit that medicine is a gray area. You're never gonna have anything that's black and white. I'm not gonna be able to sit in here and tell you that you'll never get in trouble if you do this, or you will get in trouble if you do that. You're always gonna have a gray area. So the way I try to look at it is, are you treating something versus resuscitating something? And SVT is probably a bad example, because AFib RVR can be a bad example too with the monitor, with the patient. But again, as we go through this presentation, does the patient at any time have the right to revoke their DNR? Absolutely. The patient at any time, can you say, hey, I'm gonna do this, or I would like to do this, is it okay for you to do that? And they can say, yes, they can. So again, don't make it harder than what it is, okay? And if you have to, or if you get in that dilemma, what do we have in our back pocket that can always help us out? Med control, right? And we're a team, we can talk together. So I'm just trying to break it down a little bit. Go ahead.
I think one of the other ones that throws people off too is you get somebody that wants to revoke it, but it's not the patient, I'm
It's a family.
power of attorney.
Absolutely.
So I have the right to do that. It's
Correct.
like, well,
Correct.
were you power of attorney when they signed it? You know,
Correct.
you always get in that. Like,
Absolutely.
back and forth.
And again, unless you're gonna have all that paperwork, and then what are you doing? Are you resuscitating while you're doing it or not doing it? And again, that's why, and those were questions that came up from the first group with Douglas, and all those questions came up. Use med control. You know what I mean? And I'm gonna bring up our protocol here in a minute, but our protocol basically says the patient's family can revoke it. That's what our protocol actually says. Doesn't say they have to be the healthcare power of attorney or whatever. It says their family can say, you know what? And let's face it, guys, let's face it. How many people, and I'll admit it, but I hate it, how many people have ever watched Chicago Fire or 911 or ER or whatever, right? You watch those medical drama shows, right? What do they always have on one season of all those medical drama shows? Somebody who's in there is family, and oh no, I can't let dad die, and the other one's like, that's what he wanted. It's just always a big, huge thing, right? It's a big med legal thing, and they make a huge season or 2 or 3 episodes out of it, right? So again, I'm never gonna be able to tell you with 100% what's right and what's wrong, okay?
Err on the side of safety and just do it anyways.
And I will stand firmly in, you will probably get in less trouble by doing something versus not doing something. So if you're on that line and you have to make a decision, you're probably gonna be less likely to be sued or a problem with it by doing something, trying to do the right thing versus saying, no, I don't think that's what they wanted, and just not doing anything.
What are you in here for? Save the life.
Yeah. So, all right, so defibrillate, cardiovert, or initiate pacing. And then here's the one that everybody disagrees with me on sometimes, but initiate continuous cardiac monitoring. And I use the word continuous. Can you put somebody on a monitor to just take a snapshot of their rhythm? Absolutely, I do it all the time. We just had geriatrics, and we talk about geriatric syncope being one of the biggest problems that they have, right? How many times you go on somebody and you diagnose them, even though we can't, with, oh, they're new onset RVR, or they're new onset AFib, they've never had it before, right? You take them into the hospital, you find back later they're diagnosed with AFib. So can you put somebody with a DNR CC on and go, you know what, looks like you're an AFib, you ever had that before? Well, no. What's something new? Are you educated on it? You know what I mean? And you can teach them about it. Maybe even say, hey, we're just gonna slow your heart down a little bit, whatever. Are you okay with that? Doesn't mean, DNR does not mean do not treat, okay? So again, a lot of times if you educate the patient, if you educate the family on it, you will find that you have some latitude, okay? So that being said, this DNR Comfort Care form was designed for somebody being home outside the hospital for an arrest. Okay, this was never intended to be used in a medical facility. It was intended for, you wanna go home and die in your home, you want something, so when, and let's face it, everybody does, they may even be well educated and on the whole process, but shit, dad just took his last breath, they get scared, what do? They call 911. And then by the time you show up, they've had 5 minutes to think about it, and like, well, I didn't mean to call you guys, right? Happens all the time, right? But they freaked out for a minute, or somebody did, and 911 got called. We show up. When we show up, we have some sort of obligation to do certain things, correct? So it happens every day. What I want you guys to know, and I'll pass this around, you feel free to look at it or whatever, But we have 2 DNR policies, procedures, protocols, whatever you wanna call them, in here. And one is labeled do not resuscitate, withholding resuscitation, and one is labeled do not resuscitate, just DNR. If you break them down, the first one, withholding resuscitation, I wanna break this down for you guys for a minute. It's got number 1, a pulseless patient, basically with a DNR form, okay? But number 2 says when in a medical facility has on scene either A, a properly completed state approved DNR form, B, a physician signed DNR document or DNR bracelet, or C, a physician signed order in the facility's chart for that patient, okay? So what that means to me, from a protocol standpoint, is yes, we can go to Kingston over here, and if Kingston has it in their documentation, we can accept that per our medical director and not resuscitate. We can withhold resuscitation, okay? Now, everybody's comfort level may be different with that. If you are uncomfortable with that, pick up your radio and call med control. Get them on the line, see what's going on. You know, I hate to say it, but if we got the one person who's just not comfortable with it, again, we're gonna get in less trouble by doing something. What are we probably gonna do? If Steve's jumping up and down, nope, I think we're doing the wrong thing, we need to resuscitate, we should probably just resuscitate, right? It's kind of an all or none kind of thing. Everybody's gotta be in agreement, just like when we end resuscitation. We've done CPR for a half an hour, 40 minutes, we're done. We look around, we try to get a consensus, everybody good, anything else we wanna do? Everybody's in agreement. It's kind of the same thing here. But what I'm saying is we have latitude in our protocol. And if you read down through this, you can read in here where he kind of took out the line about the doctor's calling or whatever. He's given us more latitude to say, this is not what they wanted. This is not what the family wanted. So just get med control on the line, talk to them, and see what you can come up with, okay? Mueller brought up a good point. He said he did one just based on family. I know I had one 6-7 years ago with a living will at home. We don't accept living wills. But the family was there, they didn't want it done, they said their mom didn't want it done. I called med control, we did start CPR, I think it was with Toledo, my guys just start compressions, I got on really quick, called, and we were able to stop that resuscitation in 2 or 3 minutes. And everybody seemed to be happy. Can't tell you about the patient, because the patient was dead, but that seemed to be what they wanted according to their family and everything. Clear as mud?
Yep.
Okay.
Just put it on the officer.
I mean, that cardiac, the last one, the cardiac monitoring,
Yeah.
and we all work with these people, there's just, it's gonna cause heartburn if they didn't hear it like I just heard it, like.
There are some people-
It just happened yesterday, literally.
Steve Kahan would not put anybody on a monitor.
Yeah, it just happened yesterday to me.
Alive or dead?
Yep.
We were at 41 and 20, and we were in the elevator, and we were shuffling through the paperwork. They're like, "Uh-oh!" And then somebody held up at the end, and they're like, "Take the monitor off." I'm like, "Dude, I'll take the heat for it. Just keep everything."
To me, it's a tool, right? And we just had geriatrics, and they're very hard. Like I said, their symptoms are vague. They can't relate a lot of times. So that's one more tool in my toolbox I can take and pick. Now, again, to me, the key is continuous cardiac monitoring.
Yeah.
Now, can I get on there? Can I take a 12 lead? Absolutely, according to that. You can take it, take a picture, go great, take it off. You know, it just means you're not sitting there waiting for them to go into a VFib, a VTAC, where you're going to actually provide a treatment.
But you know you can't do it, so it still doesn't hurt. I mean, you're not saving their life by having it.
Well, and I think that was the caveat here is people said, well, if I got them on the cardiac monitor, then I would be tempted to push that defibrillate button. I'm going to be pushed, tempted to.
Yeah.
So that's my theory or history on probably how that got there. It's just because, again, if you put something, but.
I mean, how are you gonna confirm if they die on you in the ambulance?
So
You're gonna put them on.
You're gonna put it, yeah.
you can put it in. Yep. So again, we're gonna talk about it in here, I think this comes through in the slides, but you're gonna see, so basically if they become apneic or pulseless, that's when the DNRCC arrest kicks in, right? The only caveat to that, and I do feel like I have to point this out to somebody, if we gave the rocuronium to take away their airway, or take away their breathing, then that doesn't count. Now the pulse, if they lost their pulse after that, that would be a different one. But I feel like sometimes I have to say that, right? It's like preparation H, why to get the label, do not, take it.
We're gonna RSI this guy.
Or
All
do
right,
not
push
eat.
it. Oh, no, he's a DNR. Okay, never mind then.
So, this slide here is just telling you who can get a DNR. And some people get a little concerned or confused that you don't have to be on hospice, you don't have to have a terminal illness to get a DNR. If you're one of those people that I don't want somebody, if I die tomorrow, my wife will kill me, But if I die tomorrow and you guys show up in my garage and I'm down and I'm pulses, step over me, open the fridge, grab a bush light and have it. Whether you like me or didn't like me, say fuck off and drink a beer, or say, hey, glad he's gone, and drink a beer and move on. I don't want it. But it's up to everybody's individual taste, right? Yeah, bush light. I'm cheating.
Just
one
I'm a
beer.
red.
We're gonna take his walk and go buy some good stuff.
Yeah.
Right. Well, if you want the other room, bourbon's in the other room, all right, sorry.
Make sure the seat's safe.
But the long story is you don't have to have a medical condition to get a DNR. You can get a DNR. Okay, how do you get one? Well, there's the website. You can go online, you can print it out, you can take it into your doctor's office, you can get it. The thing is, it is supposed to be the original copy. So again, we get into educating the public and these people about, hey, put it on their bed, put it on the, the refrigerator, put it somewhere where it's readily available, where it can be pulled out. So, who completes it? Basically, it's completed by a physician, and it can now be completed by your advanced nurse practitioner and your physician assistant. So, there's two types, we talked about them. There's the DNR comfort care and there's the comfort care arrest. Again, everything for arrest up to the point.
That's funny. Sign it. You can't sign the death certificate.
This was brought up a little bit in the last one, or the last group I taught, but it's effective as soon as it's signed, and somebody said, does it ever need to be renewed? And we did look it up, it does not. Once it's signed, it's good forever, it's valid forever, it doesn't ever have to be renewed or re-signed or
That's kind of the reason why you're not supposed to accept a copy, right? Because
Correct.
the only way to revoke that is to physically get rid of it and say, I no longer want this honored, and rip it up, but somebody still has a copy.
Your wife has 15.
Oh, they were supposed to.
So I'm gonna-
He's like, oh, no.
Well, I'm gonna go back to this for a minute. Can people write on here no compressions or no intubation? Cause I failed to mention that. This form is this form. They can't handwrite, they can't pick and choose, they can't cherry pick, they can't line this out and circle this.
Okay.
It is what it is, right? That's what it is. The form is that.
Just
Oh,
like
oh,
our cards.
Take a little bit of that morphine stuff, but not this stuff.
Morphine, fentanyl.
So again, this is what I was just talking about. So the DNR CC arrest does not become effective until they actually have a cardiac or respiratory arrest. Not a respiratory arrest induced by paralytics, but a respiratory arrest. So, okay, so if you're treating them and they took their last agonal breath and their heart's still beating for, cause it's possible, you stop. If their heart stops beating, but they take 1 or 2 breaths, it's possible. We're all different, we're all built different, you stop.
We've had one of those too. When you were at Kingston with us, when I was at Forest, we actually watched them, but we basically watched, we were there, because she went unconscious, and then she ended up dying right in front of us after we're all like playing, the whole thing's being played out, and we found that she's got a DNR arrest. We're like, all right, hey guys, she's got a DNR arrest, but she was still alive, but we're like, all right, well, clearly she's going, right? And we put the wire on, we basically just held her hand and talked to her, and she went.
Yeah. So again, this is just talking about what we will do. I think I spelled them out for you guys. They're all listed right there. This is what we will not do. Again, if you have concerns, conflicts with that, do what you feel is right for you and, the team. If you need to, call mid-control. Again, so we're not gonna prolong death. Okay? So we can provide comfort measures, but we're not prolonging death. So this is the other one that I think is really prevalent. It's in our protocol and it's actually in the state form here. Hi, Chief.
Hi.
But this is something we can definitely educate these family members on because we talk about that one DNR form.
You got one of these, Chief?
He doesn't have one, but his Barb has one for him.
Thank you. Yeah, I heard that.
What? You got one of these?
I do.
I say he doesn't have one, but Barb's got one with his
Right.
name on it. So, there are other things out there, and they're spelled in our protocol, and they're kind of spelled in here. They can have a DNR wallet card. They can have this jewelry items with a DNR logo with their patient information on it. So I think the next slide shows it's supposed to be this logo, right? But they can have jewelry or a wallet card basically with this logo that can be bought online or in the state of Ohio, that can be other identifications.
What about that tattoo?
Get that black market.
Does that
mark. As soon
count?
as they go down, you put it around their wrist.
So what I wanna get at with this is we talk about it's gotta be that original form, right? Well, they're like, well, what about when I'm transporting mom or dad? I gotta carry it with me or whatever? Technically, they can have this jewelry stuff. It's just supposed to have that logo with their patient information on it, and you can't accept that. That is a
Pretty
DNR.
soon it's gonna be a QR code.
And you're not wrong, you know?
Tattooed on them.
You gotta pick their phone up, scan their face, and then go, oh yeah, okay.
Or you just scan their implanted chip, scan the implanted chip, and it'll tell you their medical information and DNR status.
Alright. So again, how can I, ensure providers know I have a DNR, family members, caregivers, you can have we talked about this. Again, it doesn't mean do not treat. Okay. So if you experience an illness or injury that is treatable, it should be treated. Urinary tract infections, Heimlich maneuver for choking. There's gonna be a scenario at the end of this presentation where a guy is unconscious, but he broke his leg in a car accident. He's a DNRCC, what do?
Nothing.
You provide BLS. Now, if trait to split, he's breathing, he's just unconscious.
He's dead.
You just provide BLS basically. He doesn't get intubated, he doesn't get, so fractures, influenza, bleeding, right? All that stuff is treated, just don't get resuscitated. This just talks about what if somebody refuses to provide you medical care. Again, it doesn't mean do not treat. And the facility's legal counsel, if they won't treat you, they are legally required to transfer you somewhere that will treat you.
Why would we splint his leg if we're not gonna transport him?
You're gonna transport him.
If he's dead?
No, I said he's unconscious,
Oh.
but he's got a broken leg. So he can't speak, right?
Okay.
So again, he's a DNRCC.
I got you.
So he's got a broken leg, so
I
you
thought he was
just,
like an arrest.
nope, you just provide BLS. So you
Gotcha.
split the fracture, give oxygen.
No pedal pulses, he's dead.
No. So what if I change my mind and no longer want the DNR?
Yep.
Again, it says you can revoke your DNR at any time, either verbally by destroying the DNR. And if you look into our information here, per DNR, and I just want to point this out because this was questions people brought up right here. In our DNR, so our outside of facility DNR protocol, this is a valid DNR form may be overridden by the request of A, the patient, B, the guardian of the patient, or C, an on-scene physician. So according to, again, Dr. Brookins, what he spelled out, so you can get into the healthcare power of attorney or whatever, but if they can revoke it at any time if they want.
But it can't just be the family,
It does say the family.
but a guardian.
This is the guardian.
So they have to
Yeah.
be that,
And again, that's,
cause that person's signing that over to them, right?
Yeah.
That responsibility over
Yeah.
to that person.
and you're not wrong. And again, if it's one of those ones, then to me, you pick up the radio and you
Sure.
call.
Yeah.
So, and again, nobody can refuse to honor your DNR. Okay. Who can change my DNR? Well, it really can't be changed. It talks here about a healthcare power of attorney. They can only change it if they were the ones that were, let me see. Yeah, so if you have the DNR form filled out, then they're not supposed to be able to change it. If they were the one who requested the DNR, that's what I was getting at. So your healthcare power of attorney can, and again, this goes into, this is for families, this is what we're given. Feel free to contact med control. Okay? Again, just nobody can change it on you. Again, but we always have those dilemmas where family wants you to do something or they don't want you to do something, so. And again, this is where you can't cherry pick. Can it be customized and include care of what I want, don't want? No, it can't be cherry picked. It is what it is, okay? So what if you're being transferred? They should send a copy of your DNR. Everything should stay in place. They should send an original, but. So living will and healthcare power of attorneys, so just to make sure I don't miss it here for a minute.
And that's.
So again, absent a substantial change in your condition, healthcare power of attorney cannot change your DNR.
And that's subjective, right?
again, everything's
What's a
subjective.
substantial change in your
Yep.
condition? Well,
Well-
they were alive and they're dead now, so.
And we're gonna get to it in a slide or two, but there's a word, and I can't think of it, I apologize. But it's basically, it's a legal term to basically, when somebody's been, let's say, unconscious or without capacity for such a period of time, then something can change. And there's a word for it, I just can't think of it right this minute. But this is a living will, operative. Operative means that a will can be used as the basis for, so something by Ohio law becomes operative after X amount of time, and I don't know that off the top of my head. But that's not something you guys are gonna make a decision on seeing or whatever. Also, note to make sure your live will becomes operative means that live will can be used as a basis for your medical decision making. So this just says if you have both, the one that was completed the most recently supersedes the other, if you have a living will and a DNR. So here's some scenarios, real quick, I told you we're gonna be at the end. So you have a DNR form signed by your doctor, and you're a DNR CC arrest, you develop pneumonia, and the doctor say, hey, we wanna intubate you, put you on a ventilator for a short period of time. This should fix your pneumonia and make you good. Can they legally do that?
Yes.
So again, it's a DNR CC arrest, right? So it's an arrest, everything, they can do everything up to the point that you actually arrest. So here's scenario 2, you have a signed form by your doctor, you're a comfort care, you're in a nursing home, you develop a UTI, so you got a high fever, you require medical treatment, your daughter transferred to the hospital, and staff in question why you brought her to the hospital when you have a DNR CC. What is the appropriate response? Again, a DNR CC does not mean do not treat, they can treat a urinary tract infection. They're not resuscitating somebody, they're treating something. Scenario 3, you're a CC, you're a hospice, you're declining to the point your brain is very shallow, your heartbeat is weak, death is imminent, your family becomes upset and frightened and calls the emergency squad. When the rescue squad unit arrives, your family insists that they treat you and wants all rescue measures taken to revive you. How should the EMS squad respond? And again, so explain to the family that the DNR is valid since you completed it with your doctor and they will only receive comfort care measures. Again, that's gonna be one of those ones where you really have to sit there and talk to the family and explain, you know, that your mom, or their dad, or their aunt, or their uncle, that's what they wanted. And then again, if it gets to be more heated than that, then you have to talk to med control, and it might be one where you have to do something. Because again, according to our protocol, they can revoke, again, are they the guardian, not the guardian, whatever.
Or it gets to the point where you transport her to the hospital without doing anything away from the family.
That
You
can
just
work
don't-
too.
You just don't do anything while you transport her, just so you can get out of the situation.
So here's the one I was telling you about. So you're a DNR comfort care, you're in a car accident, your leg's broken, you're bleeding badly, but you're unconscious. So we get there, you have a bracelet on or whatever. Again, we treat, we bandage your bleeding, we splint your fractured leg, and we take you to the hospital. We just don't insert an oral adjunct. You're not gonna get continuous cardiac monitoring. You're not gonna get all the stuff. You're gonna get BLS type treatment. Here's the website online. If you guys have questions, you can go there. They get a lot more information, stuff like that online. There's also a phone number that you can call to get more information if you need stuff there.